everyone. Welcome to Long COVID Foundation podcast. Are you seeking answers and solutions for the lingering effects of long COVID? Well, you've come to the right place. This is your go-to channel for educational resources tailored to help you understand and cope with the challenges of long COVID. Whether you have been following us from the beginning or just joining our ever-growing community, we extend a warm invitation to hit subscribe button and become a part of our ever-curious and supportive audience. So far, we've learned a lot about the virus and long COVID. We cover topics related to genetics, gut health, microclotting, gut-brain axis, cardiology, neurological issues, and many, many more. I encourage you to watch previous podcasts if you haven't done it so. While doctors are still trying to understand long COVID, one of the things that they are concerned about is how other infections might be connected to it. And in this discussion, we will look at the connection between other infections and long COVID and why it is crucial to have precise and thorough tests to figure it out. Therefore, we have invited Dr. Armin Schwarzbach, founder of ARMINLABS, and at the same time a medical doctor known for his expertise in the field of diagnostics and treatment of tick-borne diseases, particularly Lyme disease. He is renowned for his contribution to the understanding and management of vector-borne diseases such as Lyme and co-infections associated with ticks. And without any further delay, let's give a warm welcome to Dr. Armin Schwarzbach, who will give us a talk on 3 I's in long COVID: infection, inflammation, and immune dysfunction. So let's get started. Dr. Schwarzbach, welcome to our channel. And before you start your presentation, could you please introduce yourself?
Thank you, Valentina, for this very kind introduction. So I'm not used to such a pretty woman sitting on the other side and doing this action with me. Yes, I'm, I think, at the forefront of Lyme disease internationally, and we name it co-infections for 20 years. So we were the first laboratory with a different laboratory I worked for with the tick tests in Germany. So we checked for Borrelia burgdorferi, which is the pathogen behind Lyme disease, without knowing that so many sufferers around us with this condition. And my career started, let me think about, I'm getting older now. So it started in the 80s. I worked in a biochemistry lab in at Höchst. It's now Aventis in Frankfurt, 1984. So 40 years laboratory experience now, which is 2/3 of my life. And since that, it's like a truck. If you're doing laboratory in your life, I think you will do it forever if you like it. So after that, I studied pharmacy a little. I studied biochemistry a little, but then that was not so sufficient enough for me. I'm so a little all-rounder. And I like also the English language, and I like to communicate with people. Also, I like doing maybe some other aspects like literature. So then I switched to medicine, human medicine. I studied 6 years at University of Mainz, which is nearby Frankfurt in Germany. And after that, I did a very interesting thing for 1 year. I worked in internal medicine, 1.5 years I worked in internal medicine, which included that time work with infectious diseases, with a lot of these HIV patients, Epstein-Barr virus patients, cytomegalovirus infected patients, opportunistic infections. And I had a good luck also to learn about oncology, because I learned about staging processes in cancer patients. I did a lot of chemotherapies with cancer patients, and I learned how to treat the immune system a little there. And then I learned also about cardiology, nephrology, neurology, gastroenterology. So my professors were all hepatologists, cardiologists, so high famous professors there, also nephrologists. So I learned a lot this 1.5, 2 years. And after that, I decided, because in the cancer department, all patients died. That was for me frustration. We did a lot of chemotherapies that time, but all died. That was not satisfying me. So then I went back to laboratory, and I qualified. I'm a medical doctor for that reason, MD, and I also PhD, because I did a work with Höchst Aventis with the first development of a radioimmunoassay gastric inhibitory polypeptide. So I'm also endocrinologist. I work a lot in this, I think 10 years. Developed test system, test as a scientific work, all of that. Hormones, we were a really good hormonal lab that time in diabetes and so on. And the next chapter for me was to learn more about immunology, microbiology, that a lot of cultures, stool parasites, yeast, mold, tests. I worked with in Munich after that in my qualification as a laboratory doctor, the special kind. We need 5 years for that. And I qualified in different disciplines, clinical chemistry, hematology. And then I switched to my own laboratory, which you mentioned already, which is representing Lyme disease internationally. And then the huge virus came and that forced me doing hundreds of thousands of PCR tests. So I was not the expert for that, but we did a lot of swabs, PCR, test centers, quick tests, antibody tests, cellular tests. I will explain later. And now here I am. And what I can tell you from my perspective, I think I could help some of your group because my whole career was immunology and infectious diseases, not the inflammatory part so much. I will show you also something about that. And thank you very much for your invitation. And here I am.
Thank you, Dr. Schwarzbach. Really pleasure to have you on our channel. So let's get started with your presentation.
I work a lot with different professors in scientists also in Ireland. As an example, Jack Lambert is a famous professor there at Mater University in Dublin. I work also with Christian Perron together, who's a famous professor for microbiology and immunology in Paris, France. He's now retired. I work a lot with other professors in America, and like Professor Garth Ehrlich from Drexel University, I'm on the ILADF board. That's the International Lyme and Associated Diseases Society, the educational foundation. We work on education for Lyme disease, other infections, co-infections, viruses, etc. So I have a huge network, and to me, it was clear because I see hundreds of results every day from so many patients everywhere sending me samples to my laboratory from Australia, from Canada, from USA, from Alaska, South Africa, whole Europe, England, a lot of samples I get in. And if you're a laboratory doctor, you see hundreds of results, you get an impression. And my impression was really that we need to talk about more and more the 3 big I's in long COVID or post-COVID. I know that it's not so nice to hear. In Germany, it's allowed to talk about that. Post-vac patients, we also have a challenge there with some conditions. And the 3 I want to explain you now. What I saw yesterday in the news that was not so satisfying all of us. It said that long COVID is not a major problem. So I'm completely different opinion. It's not just a long COVID to me. It's also the story of the post-vac patients, or the combination of that, or the infection plus vaccination, or the infection plus long COVID, or reinfection now, whatever you get in this situation. So in USA, the data in June 2020, it said that more than 40% of adults had COVID-19 in the past. Now the number is surely higher. And nearly 1 in 5 of those, so 90%, had symptoms or have symptoms of long COVID. So this is a huge number. That's really huge number. So the CDC is now telling a different story. So what we don't know why, and maybe it's really overestimated or underestimated. We don't have a current exact data, but this is not what we expect from the new data, because we have the data that 1 in 13 adults in the USA have long COVID symptoms. It's just in USA, it's in Germany, it's not in England. So, and it's clear that older adults are less likely to have long COVID than younger adults. Why? Question mark. It's not clear, I would say. Maybe they are more vaccinated. That should be the message for that. Nearly 3 times as many adults, 50 to 59, currently have long COVID than those 80 and older. If you agree with that, I cannot agree in all of these points what CDC is telling us. Today they tell this story, tomorrow different stories, or what. This is really a problem. Nevertheless, the 3 I's in diagnostics and therapies, to me, and it's not just my model or my reality, it's also from Jack Lambert's model, it's also Christian Perron's model, so I'm not the only one. We say, okay, we have the 3 I's we need to respect in every human being. The first I is the infection, the second I is the immune dysfunction or immune suppression, and the third I is the inflammation. And if we don't diagnose and treat all 3 big I's, we will fail. And I think that's pretty clear. This is not just the post or long COVID or post-vac model. This is also the model for Lyme disease or for all infections we are suffering in the world. This is a general model I will explain to you. You all know, and you have mentioned that about microcoagulation, microplatelets, perfusion problems. So why? Because the inflammation is there. We know that. Why the inflammation is there? Okay, maybe you go back because you have an infection ongoing, or you have the spike protein ongoing, or you have an immune dysfunction, and you get from this inflammation, or the inflammation is triggering the immune dysfunction. Immune dysfunction is triggering opportunistic infection. I will come to that. It's the main chapter of my work now, or all triggering each other, you know. So this is not clear which is triggered, so we don't know exactly. The inflammation is part of it, and we know that every infection we have in our body changes the environment from anticoagulant to procoagulant. That's clear. Why? Because also the white blood cells and also the macrophages are infected. What does it mean infected? Could a white blood cell get sick? No, they transport. Infected means more these are the transport mechanisms for spike protein, for viruses, for Borrelia, for Bartonella. They transport all of these pathogens in our bodies everywhere, or they can do that. And then we switch from anticoagulant to procoagulant, and interleukin 1 and interleukin 6 plays a role in TNF alpha. We come later to this cytokine. We have upregulation within 6 hours. It happens quickly. And in the end, we have the problem of protein C is changing to APC resistancy. And as you know, young women, they're taking the baby pills, and they have this factor 5 genetic mutation sometimes, and they have APC resistancy, and they belong to the high risk group for this sludge, for this change to procoagulant. And then they have this thrombosis, and they get maybe problems with embolic situation in the lung. So we have a huge problem in this change. This is a process every time we have that in our bodies with protein S, protein C, APC. We have different coagulation factors. So there's a balance in it, like a Th1, Th2 balance. We talk about that today too. On my agenda, I will talk about how SARS-CoV-2 acts as a viral reservoir. And in the next chapter, I will talk a little about post-COVID, long COVID, post-vac, and herpes virus reactivation, EBV, CMV, varicella zoster, HSV6, and herpes simplex virus 1-2. Post-COVID, enteroviral reactivation, which I like pretty much that chapter from my scientific work, post-COVID and association of other infections that live in the mucosal membrane, and new post-COVID viral reactivation panels, also a challenge for that. Is talking about that we know now that the S1 protein in post-COVID patients can persist up to 15 months post-infection or longer. This was a paper coming in January 2022. I didn't do more research on it, but we know that it can persist maybe over several years, this S1 spike protein. And there was a name, Peter McCullough. He said that no wonder why people have long COVID syndrome, because this spike protein, which is expressed in the monocytes, is an immunogen, so it worked also in our immune system, and therefore we have different immune reactions in our body. We will come later. And very interesting, as I mentioned, are the monocytes. The S1, the spike protein segment, infects the monocytes, and then these monocytes act as a viral reservoir. And remember back to this leukocyte slide in the beginning, from anticoagulant to procoagulant. Is this exactly the situation? If it's still living virus, or more than the spike protein or the N protein, or more than that, we cannot tell you exactly. I'm focused more on the spike protein also with my test, because they are all evidence-based, but we know that we have a reservoir for these infections or parts of these destroyed pathogens, like it is the S1 segment. We have that in our body circulating in the monocytes, and it's still working as an immunogen. So the next is about herpes virus reactivation. Herpes virus group, and very famous. We had a lot of paperwork coming out in June 2021, so over 2 years ago. It became more and more clear that COVID symptoms likely caused by Epstein-Barr virus reactivation. So we are now on the first eye. And in this paperwork, they said that 2/3 of long-term COVID subjects versus 10% of long-term control subjects were positive for EBV reactivation, Epstein-Barr virus. This is not surprising. We see that also in Borrelia burgdorferi, in Lyme disease patients, this reactivation of EBV, which means that the patient don't have Lyme symptoms, they have EBV symptoms afterwards with the fatigue and so. So that means the Professor Harley, he said, University of Georgia, that indicated to us that EBV reactivation likely occurs simultaneously or soon after COVID-19 infection. So the medicine, if you go to your GP, he will tell you in England, everybody has EBV. Everybody had or has EBV. This is now the question. Is it an active infection or not? This we need to know that. If you say everybody had Epstein-Barr virus infection, okay, but this is not the question here. For sure, the transmission in the population is over 90%. Kissing disease, come later to that. We all had that. A lot of us had that, but that doesn't mean that it's in you or me reactivated. That's a different question now. Is it active or not? So do I have it reactivated or not? This is the question, and not that I had it, because EBV persists also in our bodies, in the lymph system, in the macrophage, in the monocytes. It's circulating around us, and it can be reactivated. We all know that from the HIV model. In the 80s, Freddie Mercury time, back, we had this Queen singer. He died from HIV, and we know exactly that they didn't die from AIDS. They died from EBV infections, from Burkitt lymphoma, or some other reasons. In July 2022, in a study, 1 year later, there came again the message, the impact of EBV reactivation on the development of long COVID. This was a huge cohort of 280 adults with prior SARS-CoV-2 infection, and they found that in long COVID symptoms such as fatigue, EBV is the typical fatigue virus. It uses our mitochondria to survive and blocks and use our ATP, so we are energetically empty without any engine in our body. And also neurocognitive dysfunction. So they found it interestingly with the early antigen. If you look on the right side, the early antigen test is so important to find out if EBV is reactivated or not. It's the early antigen, EA. Please learn that during the session. You need to check for early antigen. Otherwise, you will not find out if it's reactivated. So if your GP is not testing for early antigen, you will never find out if it's reactivated or not. He will say it's a past infection. You had it, but it's not active. But he misdiagnoses you. That's completely wrong way. You know, this is a study behind that to deal with infections. And in August, there came another paper, could long COVID be linked to herpes viruses? Early data offered a hint. And they also looked or checked for other viruses, varicella zoster viruses, in the chickenpox virus. And also this paper, they said, okay, EBV, Epstein-Barr virus, which causes or has done mononucleosis in your body when you were 18, 19, the student kissing disease story. This can be reactivated, but also shingles, chickenpox can be reactivated. What does that mean? That means that you get a herpes zoster reactivation as an example, you know. So, or a chickenpox reactivation. The question is, should you do vaccination or not? We could discuss later that question. I say no, don't do vaccination. We had very, very bad outcome from patients who had active varicella zoster virus infection, and then you do vaccination in this horrible situation of Th2 dominant structures. I show you why later on. And we know also that antibodies to SARS-CoV-2 antigens and herpes virus, now the expression lytic antigens is so important. Herpes virus lytic antigens are elevated or were elevated in this paper in participants with long COVID. So what is a lytic antigen? I will explain later to you. The lytic antigen is a sign also for reactivation for active virus infection. If you don't believe that, go to Wikipedia and then you will find all of these replication cycles. I explain you later a little more about that. But now we have for EBV 2 markers. We can find out is it reactivated or not. Your GP doesn't know that. The early antigen for the antibodies and the lytic antigen in the ELISpot test in the von gamma release assay. We can clearly find out is it active on the cellular immune response, on the humoral antibodies, or both. So we have the best options to find out and the science is working on that. So we have the papers. There's nothing to say I'm talking about nonsense. So I'm satisfied with that because I was before on the way to diagnose Lyme patients more with EBV, with the lytic antigen, the early antigen, and the big virus showed me, Armin, you're absolutely on the right track. So these, I don't know to go through that, but you know, the long COVID symptoms are correlated with inflammation-induced EBV reactivation. Now we come to the word inflammation in this CDC paper. So inflammation, also they use EBV reactivation, infection, they use 2 eyes, not the immune dysfunction. They missed that, you know. Also, Jack Lambert missed that in Ireland. So he learned from me now, and he will talk about in Boston Islands about 3 eyes now, I'm sure. So he will also talk about inflammation, infection, immune dysfunction, immune suppression, because they're all 3 eyes belong, not 2 eyes, please. But also EBV infections reactivation increased the risk of SARS-CoV-2 infections. So we know that 90% of adult humans, as I mentioned, they had EBV infections. But if you had EBV infections, this infection increases the susceptibility of epithelial cells to infection by SARS-CoV-2. So if you have had a chronic fatigue before and or ME, myalgic encephalomyelitis in England, you name it, if you had the ME before and you didn't know that the reason is active virus replication with the lytic and the early antigen in your body, and then you got a SARS-CoV-2 infection, this is not a good situation. That means a higher risk for you to get more problems after the COVID. So various phenomena contribute to EBV reactivation in COVID. EBV can be reactivated by SARS-CoV-2. Chronic EBV can be exacerbated, we name its medical expression, by SARS-CoV-2. COVID EBV, whether dormant or chronic and active, can increase susceptibility to COVID, I mentioned before. And now we come to the immune suppression, which plays really a huge, huge role in all of this patient. We had some studies that time. They suggest the possible interaction between SARS-CoV-2 and EBV, and one possible mechanism was discussed, a decrease of CD8 cells, which are the primary cells responsible for immunity against EBV infection. And they found a correlation also with the natural killer cells. We are doing CD56 counts. As an example, we are doing CD3 counts for the T cells. We do a lot of immunological profiles for these patients, so we can find that out or not. EBV DNA levels and COVID-19 severity was observed. And now we come to a very, very important point for all of you. We know that it's a huge problem that the whole medical world is now using a lot of corticosteroids. So, and corticosteroids, you know, they are anti-inflammatory in the beginning, absolutely. But if you use them longer, you have the risk getting diabetes mellitus and cortisol dysbalances. And also you have the problem of a huge immune suppression. And if you're using corticosteroids or methotrexate, today I had a patient from Finland coming to me with methotrexate, and I said, "Oh, MTX was not so good for you." And he said, "Yes, why do you know?" Because it suppresses in this reactivation, it promotes the reactivation of EBV and other viruses. So that's not good to use immune suppression longer time. You could use corticosteroids for a while, but you have a high risk of these reactivations of viruses and other pathogens. Sorry, need to click the next slide. Now I want to just a short course about EBV. It's human herpes virus 4. It belongs to the herpes virus group. It's just intracellular. It's a kissing disease. It's high contagious in saliva, drinking from the same glass, toothbrush, blood, sex, blood transfusion, organ transplantation. It's a typical fatigue virus, a fever virus, flu-like symptom virus, nausea, loss of appetite, lymphadenitis, swollen lymph nodes in the neck, rashes, sore throat is a very important symptom, sore throat, weakness, sore muscles. The complications are the problem. Your spleen can get larger, your liver, so it also blocks your detox mechanism. It blocks your liver and your lymphatic system. You cannot detox. How can you detox if the virus is replicating in the lymphatic system? It's impossible. And I'm doing a lot of presentation now about cancer and these viruses and other pathogens. The non-Hodgkin lymphoma, leukemia can be also done. And as we all know, it's a chronic fatigue, the ME virus. It's a mitochondriopathy virus. It's a colitis virus. It inflamed your gut, also colitis and Crohn's disease. It's a leaky gut virus. It's a food intolerance virus. It lives in the gut. It can inflame the whole body. It's very neurotropic and it's attracted to the central nerve system. So you can get a lot of neurological or neuropsychiatric symptoms. This is now how we can diagnose. Please do the early antigen. Ask your doctor for the early antigen. Then you know if it's persistent or chronic or reactivated or not. And do additionally the ELISpot with the lytic antigen, because this is a sign for the replication. If the virus is sleeping, snoring, I name it, you find the latent antigen without the lytic antigen. But if you don't understand, I explain individually in results or reports, or go to Wikipedia, Google it, and then you know. This is how reports look like. There are different markers. Please don't be worried about that. This is my job of the laboratory doctors, my infectious disease doctors. This is clearly a reactivation with the EA, which means the early antigen in the IgM antibodies, and the IgG P138 band. This is a clear reactivation. And this is how it looks like the lytic antigen, massive replication of this virus, high active EBV infection. We don't discuss about that. It's an evidence-based test. It's CE certified, UCAS allowance. It's CAP, American accreditation, German accreditation. It's validated. So there's no discussion. It's a transplantation medicine test, also for kidney and liver transplanted. Preferences, you could get that if you're interested in your doctor. You can learn a little about that more. But it's not just EBV. we have also cytomegalovirus. We forgot the cytomegalovirus, CMV, which belongs also to the herpes virus group. And there came a paper in 2021, a CMV reactivation and virus-induced immune dysfunction may be underestimated as a driver. And we know now that also CMV plays a huge role in long COVID, post-COVID, post-vac patients. And it's an effort to do that. But as you know, I don't think NHS is caring about that pretty much in Germany. Also CMV, we forgot about that. We care more about EBV, Epstein-Barr virus, but not for cytomegalovirus. Why? I think it's not okay that we are doing ignorance, because it also can do thrombosis. There's a lot of proof about that. 2005 studies about that on the coagulation system. That's old story. It's nothing new, you know, with the SARS-CoV-2 spike protein. All of these viruses can do that, or pathogens can do that. Cytomegalovirus influences the coagulation system. You have the paperwork, you have the studies. You will find a lot of other studies earlier times, but what is it for a virus? It's similar to EBV. It's not far away. It's in the body fluids, in urine, saliva, breast milk. Also for your baby, it could be a problem. Sexual transmission, organ transplantation, blood transfusion. It's a fatigue virus, fever, flu-like symptoms, lymphotropic virus, swollen cervical lymph nodes, sore throat virus, splenomegaly. Congenital infection is very dangerous. It's hepatitis virus. It's also retinitis infection of the eye, pneumonitis, esophagitis, polyradiculopathy. So it's highly neurotropic. It inflames your nerve system. You have pain, you have numbness, whatever. Transverse myelitis is a form of multiple sclerosis. Superacute encephalitis, hypertension, also because it infects the endothelial cells, and then you get atherosclerosis and or also biofilms. They're all doing biofilms, maybe to mention all of these pathogens doing biofilms. Atherosclerosis, aneurysm, and associated, unfortunately, also with non-Hodgkin lymphoma, chronic fatigue, ME virus, mitochondriopathies, colitis, leaky gut, food intolerances, very neurotropic. How can you diagnose? We don't have an early antigen in the world. We have a lytic antigen, which is pretty good test. I find a lot of lytic antigen positive in the patient, and then you need to treat. And not everybody has this, okay, to answer your doctor's question. Some had it, the latent antigen, or they had it never, but some have, unfortunately, this lytic replication of the virus, and it's active in the body, replicating and treatment. This is what we see really early, that COVID, before COVID, in May 2009, we had patients with CMV lytic antigen. It was 13 that time. We didn't do the latent, but in June 2020, after COVID, it was an explosion of the lytic antigen in the same patient. So that means it's more reactivation of lytic antigen, latent antigen 79, so a little under control, but a massive replication of this cytomegalovirus, which needs treatment for sure. And the patient has they have the symptoms for sure correspond. But the virus. It's a chickenpox virus. And in this study, if you say, okay, vaccination doesn't play a role, yes, it plays a role. It's published. We know also that the post-vac could mean to patients varicella zoster, herpes zoster reactivations. So we have the paperwork about that. So it's published. This is another paperwork that COVID-19 can potentially cause the activation of varicella zoster. And the question is, do we do a vaccination now or not? This depends on the test. We'll show you how we can give you a better decision if you need a vaccination or not. Varicella zoster virus, what is it? It's airborne, it's high contagious, chickenpox virus. It's flowing through the air, so over feet and meters you can get infected. It's high contagious, and it's in these blisters on the skin, on the lips. You have fever, you have tiredness, you have loss of appetite, headache. also bronchitis, zoster. Maybe you know Justin Bieber. He has this. He canceled his tour because he has Lyme disease. They have written, and he had this Ramsay-Hunt syndrome, so painful blisters on tongue, ear, facial weakness, hearing loss. So, and he could not do his concerts last year. And also these varicella zoster virus, please don't underestimate this virus, the chickenpox virus. It inflames your arteries. There are huge studies about that, about strokes. In 2017, they checked 23,000 patients with herpes zoster before. This not dependent on the long COVID story. And they got high risk for stroke, 35%, and heart attacks, 59%. So it's highly inflaming your endothelial cells in the arterial system. Chronic fatigue virus, mitochondriopathy virus. So now we come to the test. The best test, I would say, it's the IgG, IgA antibodies, and the IgM. I think before you do vaccination, you need to do that because if you have a high titer for IgG and maybe a titer for IgA, why should you be vaccinated? If you have a high titer for IgA or titer for IgA, this is not normal. You have a reactivation in your body, and we never should vaccinate patients who have a IgA expression, who are active, coming to us doctors with an active infection in the body without knowing that. Maybe it's caused in the ganglion, in the deep tissue in your body. Why? Because the IgA is the best test. We have that. It has a half-life time of 2 weeks. The ELISpot is not so good work, not so strong working. Sometimes we find positive ELISpots. But the IgA is for me the marker in combination with IgG and IgM. And if IgA is positive, don't boost. Why should you do a vaccination? Why? There's no reason for that. Simplex of the lips. Also, reactivation could be in patients with long COVID and severe pneumonia. And also we know that this virus has a high incidence with these pneumonia patients from the intensive care. That came pretty early, this paperwork. So we knew that years ago. What is a herpes simplex virus? It's herpes simplex on the lips or genital herpes, which is not the main issue. Highly contagious, transmission cellular, all intracellular, doing biofilms, always the same. Sharing drinks, so sharing the same classes. Sexual transmission also possible. It likes the mucous membranes of the mouth, of the lips, of the genitals. Anus, flu-like symptoms, fever, muscle aches, swollen lymph nodes, lymphotropic problems, urinating, the herpes keratitis, multiple sclerosis. We know that a lot of patients with herpes simplex virus suffer from multiple sclerosis later on. There's a clearly association, a lot of papers coming out now. Loss of vision, encephalitis, and also the immune system plays a role. Chronic fatigue virus, mitochondriopathy, colitis, leaky gut, food intolerances. How can we diagnose? IgG, IgA, IgM, this is the best test. IgG, IgA, IgM, there's no vaccination. Don't be worried. You're not threatened by that. Varicella zoster can be a threat for you, but not the herpes simplex vaccination. It doesn't exist. HH6 and COVID-19. Sorry, und it's German, it's and. So there came a paper also about human herpes virus 6, which is also a virus of the herpes simplex virus group. And they found 22% in long COVID patients in post-COVID in intensive care unit. So this is a reactivation, very, very common in this long COVID group, with also together with EBV. So that's interesting. This paper was one of the first. They checked different pathogens in August 2021. 1 year ago. They checked for human herpes type 6, HHV6, and EBV infection. They found both infections active in some of these patients. So it's a double infection. So believe me or don't believe me, every patient I see has multiple infections, also with a long COVID, post-vac, Lyme disease, whatever I diagnose, they all have multiple infections. It's not just one patient with one infection. So all of these papers are restricted and limited. Most of these papers or published papers, they didn't respect other infections and they didn't check that. This paper was good. It checked EBV and HH6. They didn't check CMV, herpes simplex, varicella zoster, Coxsackie, chlamydia. They didn't do that. So the study design was also limited. It was not a good study, also, although it checked for 2. Human herpes virus 6, exanthema subitum. It's a childhood illness which can be reactivated. It's high contagious, saliva and salivary glands. Multiple sclerosis virus, highly neurotropic, neuroviolent. It's a cofactor in ME, chronic fatigue, fibromyalgia, pathogen, HIV problems, cancer patient, Hashimoto's, also Hashimoto's patients need to be checked for HHV6, liver dysfunction, liver failure, chronic fatigue, virus mitochondriopathies. How can we diagnose? I think we have really 3 good tests. What I see, the ELISpot is wonderful, the IgG/IgM is wonderful designed, and the PCR. So the PCR, we find some of the patients with positive antibodies or positive ELISpots positive by PCR. And the question is, how high is your viral load in the bloodstream? In this case, HHV6, it makes sense to check in positive antibody situation or positive ELISpots or both, the PCR from your blood. Post-COVID and enterovirus infection. This was also a challenge for us for years now. What is an enterovirus? It's a gut virus. How does it come into our body? Via aerosol or ingestion, highly contagious. It replicates in the tonsils, and then it replicates also in the gut, in the Peyer's patches, it's named. And then this virus is for some weeks in the feces. So if you go to a restroom, it's also for children a problem in kindergarten and school, and then they go to restrooms, the other child can get a smear infection or could get a inhalation of this virus, and then they got sick, and the whole kindergarten is sick with echovirus and with echovirus and these Coxsackie virus. Poliomyelitis virus belongs also to these enterovirus groups. You see that here. The problem is not that you get infected. Maybe the problem is how you can tolerate, how you're coming over that infection. It's the hand, foot, mouth disease. I will show you an interesting picture later on. The herb angina, it's a rash. It can also do myocarditis, pericarditis, pleurodynia, encephalitis. So it can move everywhere in the body. But please remember, the originally is the mouth and the gut. And there was a famous doctor, Byron Hyde, was in Montreal, and they took his license away, and he did this Nightingale Foundation, and he said, okay, we have a lot of patients with ME and Coxsackie virus, and I met him in London years ago. After that, they took his license away in Canada. So, and really, this virus survives also in the stomach. In the stomach biopsies, they found in ME patients this virus. Who knows that? Nobody knows that. Coxsackie B virus. So it's clear there's a high correlation with it. And why could it survive in the gut tissue? And we know also this, as I mentioned, this virus can be a problem also in post-COVID, long COVID, myocarditis, pericarditis. These are the patients with heart arrhythmia. So we know that Coxsackie B virus is a huge problem also in long COVID. And what we know, remember back what I said, the role of SARS-CoV-2 infection in your mouth. And I will show you now why. This was my patient today from Finland. I asked him different questions. I asked him, did you have some diarrhea during childhood? And when you were younger? Yes, I had a diarrhea. And do you have sometimes blisters in your mouth? And he said, yes. Why do you ask this question? He was from Finland. He was sick. He had joint arthritis, fatigue, ME, you would say. And I showed him that picture, and he said, yes, that's me. Yes, this is a Coxsackie virus infection during his lifelong. He didn't know that, He was treated now with methotrexate, very bad outcome. Corticosteroids help temporarily. So this is Coxsackie virus, active infection in your body for years, reactivated. You see that. You can lose your tonsils. They do tonsillectomy. It doesn't make sense. They give you antibiotics, no sense. Why? Because this is a Coxsackie virus. It's a virus. And this is coming also from the gut. It survives, and to see the inflammation also there. Virus. That's the most common virus, number 1 infection in the world, I would say, what I see in my results. 95% are active in that. It's highly contagious, enterovirus, very small virus. It can easily spread from person to person. As I mentioned, fecal oral contamination, it's high contagious like SARS-CoV-2, droplets of fluid from sneezes, and if you cough also, you can get it in the airplane, you can get it in the underground from others. Body fluids also high contagious, utensils, toys, diaper changing table. It's a gastrointestinal from entero, means the gut, and it has an intestinal permeability. I showed you. It's hepatitis, hand, foot, mouth. I cannot go through all of that. We know it makes fever, rashes, sore throat, diarrhea, especially cough, fatigue, conjunctivitis, loss of appetite, headache, night sweats, also very typical. And what is a tragedy? I know some young adults, they got this insulin-dependent diabetes mellitus type 1. So it makes autoimmune disorders, a lot of autoimmune disorders. And this started during childhood. The younger ones are not diagnosed with that. They had some diarrhea, some herpes angina, and then they got this autoimmune destruction with this Coxsackie virus of their pancreatic gland. And then they got insulin-dependent diabetes mellitus. I think we could prevent a lot of these younger if we think more the pediatric doctors about Coxsackie virus infection, and then we need to diagnose and to treat. So it's pretty clear what to do. It makes also multiple sclerosis and a lot of infection of the brain. It's chronic fatigue virus, ME virus, mitochondriopathy, colitis group, leaky gut group, food intolerance is very, very neurotropic. My niece nearly died from this virus. She fell into coma some months ago. Nobody knew that. We found that out. She had blood pressure 200 to 100. She's 9 years old. She survived. Now we treat her for this virus, and she's getting much better. She's now walking around and doing some sports back again. The echovirus, sorry to mention that too. Echovirus belongs to the enterovirus group. We forgot a little about that. It's also high contagious, respiratory droplets, body fluids, gastrointestinal from entero, intestinal permeability. It may involve breathing difficulties, cough, mouth sores, again, sore throat, fever, chills, chest pain, severe headaches, photosensitivity, and this is now the story about ME, so that in 82% of the stomach that this virus plays a role in ME in over 80% of the patient. And if you have that, so now doctors, you go to your GP says everybody has this, you say, but everybody has this active, or reactivated. That's the difference. Mitochondriopathy, colitis, also of this echovirus, very neurotropic, attracted to central nervous system. How can we diagnose? We have the perfect test. This is 100% specific and very high sensitive. We find 90% in this selected group with the IgA test. IgA, why? Because the IgA has a half-life time of 2 weeks. It's highly specific. It's not a polyclonal stimulation, not unspecific reaction. IgA is an immune protection, also against the spike protein. We test of IgA. And what is IgA? IgA is the active infection. If you don't have IgA, it's not an active infection. This is how reports look like. Massive infection of this patient with IgA, Coxsackie virus B1 and A7, so double infection of both. IgA is positive, both IgG is positive, so that's not a fresh infection, the current, very current. It's a old infection, reactivated or persistent or chronic without knowing. So now I come to these mucosal infections, and you know, I'm sure, about mycoplasma. We know that 70% of ME patients suffering from Professor Kath Nicholson's studies, ME patients suffer from mycoplasma infections. Mycoplasma likes the fibroblasts you see on the right side, and it likes the surfaces where you have mucosa. It's a mucosal infection. All of these infections are like the mucosa IgA production also. So this is a huge infinity for mucous membranes, the whole respiratory system, small intestine, vagina, fallopian tubes, uterus, structures, so it can live everywhere. Vesicles of the brain circulate cerebrospinal fluid, so it circulates in you. Maybe you know the Guillain-Barré syndrome, which is a tragedy. Also, cilia of the eyes, synovial tissues, makes also arthritis, and it's going deeper. It's inflammation. It destroys your epithelial cells, endothelial structures. It makes it more porous. Inflammation, immune dysfunction, infections, all 3 I's. This is my bacterial infection number 1, I think, diagnosed in the world. It's Chlamydia pneumonia infection. It lives in the mucosal membranes. It's a reservoir there. It's doing a lot of problems in your body: Alzheimer's disease, multiple sclerosis, schizophrenia, atherosclerosis. It's bacteria. We're talking about bacteria now. It's not virus. Asthma, cancer, cirrhosis, diabetes, bacteria, arthritis, rheumatoid arthritis, fibromyalgia, Behçet's disease, and it uses also the endothelial cells, and we have endothelial dysfunction, and it affects also the nervous system and the heart. So, and it remains in the epithelial cells of the mucosal membranes. It's a reservoir of this chronic infection. And then it depends on the immune system if it's reactivated. Some of the patients have it in the lung, and then they spit out a biofilm. This is some kind of slime. The smokers especially have a problem with that. So you spit out the biofilm, the slimes, the protection, and the communication area is a biofilm of these pathogens. Oxidative stress, inflammation, association with chlamydia pneumonia and cardiovascular disease. We have also paperwork about that. We know that very important is the oxidative stress and inflammation, by which chlamydia pneumonia may contribute to early as well as late stage of the atherosclerotic process by promotion of the endothelial dysfunction, foam cell formation, platelet activation, and thrombus formation. And here we are back again, remember back, anticoagulant, procoagulant. So it's also doing that. It's not just a problem of EBV or spike protein. A lot of these pathogens doing that if they are reactivated. This is how it works in this slide. It promotes the endothelial dysfunction, as I mentioned, and it's a pernicious combination alongside following COVID infection. So you got atherosclerosis, you get cold hands, cold fingers. Also, my patient today had this. I shaked his hands and I said, "You have cold hands, you have a microperfusion. Maybe you need some HELP apheresis," which is a good method also to bring away this sludge temporarily. Professor Jäger is doing that here nearby Munich. So it helps for sure, but it doesn't help against the infection, which is active. You need also to treat the infection. You need to treat the immune dysfunction, and you need to treat the inflammation. HELP apheresis alone will not solve the whole bunch of problems you have in your body. There's a high percentage of respiratory pathogens associated in this study, chlamydia pneumonia and others. They found rhinoviruses, enteroviruses. Here we are, chlamydia pneumonia, mycoplasma, coronavirus, adenovirus, parainfluenza. So they found a lot of these viruses and also chlamydia mycoplasma in these patients with respiratory problems post-COVID. Chlamydia and mycoplasma both contribute to persistence. There came a study of 443 patients with SARS-CoV-2 infection. Two individuals had an antibody positivity against mycoplasma and/or chlamydia, so they checked for both. That was good in this study. And how do they do that? Or how did they do that? On the right side, you can see IgA antibodies, so that's my way for years now. So I'm the Pope for that. Do the IgA, IgM could be helpful. IgA is the key of these reactivations and persistencies. And here you see a report that the cytomegalovirus IgM or chlamydia pneumonia IgM is not helpful. The EU NHS is doing in England the IgM for chlamydia pneumonia. It's not helping. It doesn't help. Just in very fresh infections, but this is not the question we are dealing here. We need to do the IgA. We don't have it for cytomegalovirus, therefore we do the ELISpot with the lytic antigen. IgG is produced in a delayed response to infection and can be retained in the body for a long time. IgG without IgM means a past infection, but this is not true because we don't have an IgA test for that, and we don't, this doctor didn't check the ELISpot test, the lytic antigen. So that's why IgA antibodies are very important in our diagnostics nowadays. They are found in the mucous membranes of the lungs, also IgA for SARS-CoV-2. After vaccination, they have such huge titers. We see that's I cannot tell you how high. I'm so shocked about that. And then they do booster on that. They get reinfected. Why should you boost the patients with IgA, IgG antibodies? There's an active infection still. It's ongoing. Something immunology doesn't work. The IgA is the only antibody produced in the mucosa. The only antibody. IgM and IgG not. The advantage is the half-life time, as I mentioned, 5 to 6 days. So half-life time means 50% of this protein concentration should vanish. Post-infection, if it doesn't vanish, there's something going on with the replication of these pathogens. Don't do IgM in chronic infections. We should leave that way. And in stroke patients with chlamydia pneumoniae, they found 60.8% IgA antibodies in a huge study 2011. So that's the old story, atherosclerosis, strokes, IgA production. This is how double infection, chlamydia pneumoniae, and mycoplasma, double infection, IgA. These patients for sure have problems with it. I don't know the story behind that, the analysis, the differentials, but if you have such, this is not healthy. You need for sure to be treated away the IgA and to do the seroconversion to IgG. IgG is allowed, IgA is not allowed. IgA antibodies can indicate active infection with chlamydia, mycoplasma, Yersinia, Campylobacter, varicella, Coxsackie. Wherever we have the test, it's the best test we can offer. This is a double infection, the same patient, chlamydia, pneumonia, IgA, and Coxsackie virus B1. But you can see here, not every test is positive. So the doctors, every test he's doing is positive. That's not true. The IgA for subtype A7, it's negative in this. So it's not everything positive. If doctors don't understand, they should ask experienced laboratory doctors and not tell patients such nonsense. That's misinterpretation and is leading to wrong consequences. So now coming to the end nearly, new ARMINLABS post-COVID viral reactivation panels. So in England, we are working together with the Academy of Nutritional Medicine for years now in this field, and it's no longer new, but we developed early test panels for post-COVID, long COVID patients, post-vac patients. I can mention here in Germany, not in England. The EBV ELISpot, lytic antigen, the cheap panel, ELISpot, CMV for the lytic antigen only, varicella zoster IgG, IgA, and Coxsackie virus IgG, IgA. This is affordable panel. Better would be and more satisfying to know more about your reactivations. You do the ELISpot for EBV, the CMV, varicella zoster IgA, Coxsackie IgA, herpes simplex IgA, HV6 ELISpot, chlamydia pneumonia, and mycoplasma IgA, and then you find your explanation why you are still sick, being in the long COVID group. And if you don't believe me about this ELISpot, there's a handbook about that. You can go into deep. The quantification of this interferon gamma release assay is an invaluable technique in immunology. So I just can agree. This is a teaching book from 2018. And the story went on. As you know, there is also a company in England. They offered the cellular tests after vaccination and to find out if you have immunity or not. There's a good question with immunity. I don't want to discuss that today, but we're doing now the iSpot. What is an iSpot? The iSpot is not just an ELISpot. It includes the iSpot, also the interleukin-2. And some of you know that interleukin-2 is one of the main cytokines for past infection or past vaccination. Interferon gamma is always the marker Th1 for currently active infections. So if you have corona, you are active, you are sick, you are allowed to produce interferon gamma and not the interleukin 2. This is coming later, after some days, some weeks. But if you're still producing interferon gamma and interleukin 2, there's something wrong with you. This is for all infections. That's the new but it's the next generation testing we are doing. And this is what I never understood. I was on the forefront. I was the first laboratory in Germany doing this test 2.5 years ago. We did a lot of these spot tests after vaccination, what you can see here. The interferon gamma after the infection is still positive after weeks. It was a patient after weeks. And the interleukin 2 is also positive. So this is still interferon gamma production. Why? The spike protein is still immunogen, and it's still an ongoing like infection. And I would not do vaccination in this situation, to be honest. If you just have interleukin 2, not interferon gamma, it's allowed. And if you don't have IgA antibodies, the IgA antibodies, and you have just IgG antibodies, the question is, how high is your titer? You know, not all against the vaccination. It also rescued a lot of lives. That's not a discussion, but we need to care more about immunology before we do something with our bodies. And we need to know, do I have enough antibodies, or should I vaccinate again and again and booster and over booster myself, that maybe I get autoimmune disorders by Th17 pathways? That doesn't make sense. And what we did in this period, we developed this free of any cost. You could get it from AONM also. You see here the address at the bottom. It's on the website. You can download. And if you have long COVID, please fill it out. And then you know it's a symptom checklist. And behind that is artificial intelligence. I worked on that for years with Lyme and co-infections and also other infections. We have a now parasite checklist also. We are missing a yeast and mold checklist, but it will come for sure. We're working with clinical symptoms, and not every infection is doing every symptom. That's clear, okay? So Yersinia is not doing every symptom as it is with EBV or parvovirus. Parvovirus plays also a role in the reactivation. We could not talk today about that. But if you have some symptoms, the algorithm, the artificial intelligence tells you the more symptoms you have for an infection, the higher is your ranking to suffer from this infection reality. Okay, this is how medical brains are working, what we studied, or the teaching books are telling us. It's a differentials and algorithm behind that. And coming back now to therapies, that's the last point. I want to tell you where we are going a little in the world, or in Germany and USA. The 3 I's we need also to treat. We need to treat infection, we need to treat immune dysfunction and inflammation. And when I started with that, all the doctors, they said, we cannot do anything against viruses. We cannot do anything against EBV. I said, we need to do something against this. Why we could use acyclovir, ganciclovir, valaciclovir. It's better than nothing in this patient to improve, to reduce the viral load. But the way is now also to check the stress. You know, the stress plays such a huge role. Also in my patient today from Finland, he had sleeplessness, anxiety, mood swings. So all of this is stress triggered. You know, reduce the stress. Whatever you can do with your stressing factors, please work on that. Otherwise, you will not get healthy. You work against your natural immune system. You work against your gut. Also, your nutrition plays a major role. 80% of the immunity is coming from the gut, and the adrenal fatigue. You know, the hormonal axis is so important. Also, adrenaline, cortisol. You need also to reduce your stress. That's easy. You could try that. And from is antibiotic world, long-term antibiotics. This, I think, it's not the solution for the future, because we find a lot of virus infection and parasites also now. We used a lot of antibiotics in the Lyme world, but we know that an influence on the microbiome and mitochondria, and we destroy the natural immunity of the gut, and we cannot repair that easily. So in this PLEASE study, it was clearly documented 2016. So I'm not the fan of antibiotics any longer. I was it before, but not nowadays. So what we're using more is immune modulation, vitamins, minerals, probiotics, chelation are using for detox, some detoxifications. We're using, or we doing some herbs, or some therapists doing herbs, not me, alternative pathways. I think it's a must do to use biofilm breaker nowadays. When I learned that we had 3 ones, it's a lamprokinase, serrapeptase, and the nattokinase. These are the 3 big ones. Biofilm breakers drink a lot water without gas, otherwise the biofilm breakers don't work in you. We know that 3 liters minimum. When you sweat more than that, the vitamins could be vitamin A, B complex, vitamin C, also quercetin, vitamin D, also vitamin K2 important in the combination. We have learned now during SARS-CoV-2, magnesium, coenzyme Q10, essential fatty acids. There's a huge discussion if this just the market for some companies to sell that, but I'm convinced that it helps you. If you have enough vitamins and you have an inflammation of the gut, you need more vitamins in your body. Use the probiotics, could be a tip for you, lactobacillus, prebiotics. What I've learned early was the Meyer's cocktail, this infusion therapy. Professor Meyer from Johns Hopkins University invented that, I think 15 years ago. We used in Lyme disease that Meyer's cocktail, vitamin C, higher dose, vitamin B1, combination B6, B12, dexpanthenol, and magnesium. It's 1 infusion per week, around 60 minutes. If you have a doctor who could do that immune booster, good for you. But also what we're doing now, a lot of glutathione infusion, artesunate infusion, curcumin infusion, alpha-lipoic acid infusion. These are the infusion part. If you can do some of this, I think it helps some of you, not all of you, but you could support your immune system. Where I'm the fan, it's more the herpes, to be honest, because I'm using myself for my virus infection. With the Coxsackie virus, a longer story also to tell you, we have a lot of herpes coming from the nature, not dangerous to us. Samento mandrol, this was Lyme disease story for bacteria like Lambert commanda, quina. Now my 2 favorites coming in my life, it's Tacuna and Hotunia. If you have the time, please look at or read the book from Stephen Buhner, Buhner. There's a lot of these herbs, a lot of literature behind that described and what it is, what it means, evidence-based, some of these papers. Noni, Pandrol, Berberry, Glucane, procyanidin, melatonin, for sleep, DHA, selenium, zinc, magnesium. And sorry to go back, we need to support the Th1 system because you switch away from Th1 to Th2 after a while. This could mean some years, and then you have an overproduction of antibodies, and you lose your cellular immune capacity, to say in easier words. And then you need to support the Th1 system to bring it into this equivocal situation against with Th2. You should do that. I cannot force you, but do it, and then you will feel better. Also, we support in some patients when we have a weakness of the Th2 system. Mur, very famous. Sorry, not so many. Here it is. Sorry, go back. Statins, progesterone. There are not so many. Adrenal fatigue, we also treating with some herbs, Schizandra, astragalus, Rhododendron caucaseum, ginseng, famous in Germany, rhodiola, stress, anxiety, amantilla. And when I started years ago, when I found out that not everybody has Lyme disease, where I was convinced for years, being on the islets board, also in America with Borascana and Horowitz and all of these good guys there, caring about chronic Lyme. We found a lot of viruses, and that was the time when I said, why not do combination or easy and not so expensive? So to me, what I could tell you, it's Tacuna and Totunia in a combination, the herbs, Berber, Pinella, it's combination of detox herbs for your liver. Samento, it's good also against chlamydia, mycoplasma. Serrapeptase, it's just an example, biofilm breaker, and to me, every day, L-lysine, it plays an important role, L-lysine. Also, after while there was more signs on transfer factors, it's named. Multi-messenger is one of these to support the natural killer cells, ATP fuel, transfer factor, Lyme plus, that's Lyme disease, messenger N1, Mycoplasma, chlamydia viruses, serrapeptase again, stevia also became famous, artemisinin, curcumin, don't forget the curcumin in this anti-inflammatory part. And thank you very much for your attention.
Thank you very much, Dr. Schwarzbach. Very impressive work. Thank you for sharing the story about all these viruses and the role, most probably, they play in long COVID symptoms. That was really informative. And we will go now to part 2 of our discussion today. I will have some questions to you to explore a little bit deeper and considering your experience in this field, if that is okay.
Yes,
so,
for sure.
Your work often involves identifying co-infections in patients with tick-borne diseases. So are the co-infections that you have found to be particularly common, and do they pose unique challenges in long COVID cases?
That's a very good question. We didn't talk about Bartonella, we didn't talk about Rickettsia, Babesia, Ehrlichia anaplasma, we didn't talk about Toxoplasma, we didn't talk about Toxocara canis, we didn't talk about other parasites like Ascaris. Yeah, where to start, where to end. So when we did this checklist, we were focused, also yeast and mold is not in this chapter, but we put it into this long COVID checklist, you know, so we didn't name that post-vac, but it was pretty clear that also the way is for this patients group or a problem with this opportunistic. The word co-infection I don't like, to be honest. I don't like the word co-infection. Also in islets, what is a co-infection? What is my main infection? You know, I'm a profiler. We check for different pathogens, and I tell my patients not every infection is active in your body, but some maybe, or nothing is active, okay? And then they say, okay, it's good to know my direction, which pathogen is active, then you know what is active. And in the end, it doesn't matter if you have 10 viruses active or 5 viruses. If you have 5 viruses active, I think it's enough to do a virus treatment. If you have 3 bacteria active, it's okay to do bacteria treatment, but you need to have some direction in this profile. You know, this is the beginning of artificial intelligence, of this complexity of these 5 different pathogens. We have the bacteria, we have the viruses, we have the parasite, we have the yeast and mold group. These are 5. You know, these are teaching books, and if you want to bring this into artificial intelligence, it's a huge chapter doing that. And then you go into the teaching books, and then you find, oh, oops, this teaching book is telling different symptoms than the other teaching book. Why? Because these professors, they did this characterization of different pathogens. They didn't check for profiles. They just checked for one infection. You know, there's also in England, you have this Lyme disease. It's rare diseases. They didn't check for other infections, for viruses. They just check for Lyme disease, you know, and then they say it's not Lyme disease, but maybe it's a different co-infection, as you named it, Bartonellosis. You need to check that also, because in the ticks, ticks transmitted. You cannot say now it's not Lyme disease, it's not a tick-borne illness. That's a nonsense way.
This is because some of the patients do tell that they've been tested for Babesia positive, and after an appropriate treatment, they recovered from long COVID.
Yeah, Babesia is a parasite. It's like malaria. And maybe to mention also, then you need an antiparasital. And today my patient had hydroxychloroquine. And he asked me the question, is it good? I said, yes, you have night sweat. Maybe you have Babesia, take it. Hydroxychloroquine helps also in rheumatoid arthritis. It's a long-term antiparasital. But you need to know what to treat. You need to know a direction. If you don't have a direction, the people are they taking such strange therapies now with disulfiram. They don't know what to treat. You know, I'm a doctor. I want to know what to treat. Otherwise, I get lost in my system.
Absolutely. So could you share your insights into potential mechanisms, or let's call them pathways, through which those infections that you mentioned today, and maybe Lyme disease, as you're expert on that, might interact with long COVID and leading to persistent symptoms in long COVID?
Yeah, also Borrelia. We have also a paper I didn't show today. I have that paper. Also, it came this year or end of last year, that it showed clearly that if you have Lyme disease, you have a higher susceptibility for SARS-CoV-2 infection. So because Borrelia suppresses your immune system and makes inflammation, it's pretty clear. So you're damaged without knowing maybe, and you don't know if you have Lyme disease because your doctor in England says you don't have Lyme disease, it's psychiatric. Take antipsychotic remedies. Now I'm not attacking systems. We know that we need to work on that by education, by discussion, but the problem is the guidelines don't allow this discussion. Also in England, not. It's you have the NICE guidelines for Lyme disease, they don't allow that. And for sure, if you treat Babesia and you have a reactivation of your Babesia infection where the night sweat, you didn't know that, you treat Babesia with hydroxychloroquine, you feel pretty well. Okay, the job is done. The patient is maybe cured. Long COVID has gone. That's wonderful. That's what we need to do.
Are there any specific laboratory markers or biomarkers you frequently monitor in these patients? And is there any correlation in these markers in long COVID cases?
Yeah, I have our own presentation. The time is not there about
Yes, so maybe we can schedule
CD.
something for next time to talk specifically on
I did it pretty early, when it was when we had a laboratory crisis because logistics, nobody sent us sample. We had lockdown laboratory and I was fighting to survive in 2020. I sent all my employees into home offices, no work. And during that, I said, okay, we need a cluster of differentiation panel, that's CD clusters. It's not expensive. Let me say 80 pounds, 90, 100 pounds. You get the CD3, CD19, you get the CD57, CD56, and then I think all about immunology. And then where's the weakness in this patient. What we see astonishingly, a lot of patients have chronic virus reactivations without knowing. They have very low CD3 cells. And by that, the CD8 low, CD4 low. And this looks to me like I treated my HIV patients. Also Jack Lambert, we have the same. He was an HIV specialist. He's a little older than me, but he also treated HIV patients before me. And we talked about, and we know that, the HIV model is the right model, but patients are not suffering from HIV infections, but it's a model, the immune suppression, the opportunistic infection, the low CD3 cells, the non-natural killer cells, and we need to support this, and we can monitor that. It's so good to monitor that, to see that. There's no discussion that the test is not good, that it's not accredited or whatever. It's not skeletonism, it's immunology.
Sure. And in cases where patients have both diseases like Lyme and long COVID, what would be treatment strategies that you found to be effective in managing their symptoms and improving their quality of life?
As I mentioned to you, the antibiotics are not the first choice, although you have maybe Lyme disease or Bartonella or Ehrlichia anaplasma or Mycoplasma. There are different facts. First of all, the gut is already damaged, okay, because a lot of these patients have infection of the gut. Yersinia, Campylobacter, cytomegalovirus, Coxsackie, without knowing. Inflammation in the gut. Then they have a wrong nutrition. They eat bad stuff. They eat a lot of heavy metals, a lot of toxins. So the nutrition is getting worse in the world, everywhere. This is fact. If you go everywhere in the world, the nutrition is not the best. So the gut means 80% of your natural immune system. As I mentioned, the microbiome is destroyed by the infection, inflammation, maybe from antibiotics. Don't use the antibiotics in the first line. And believe me, all of these patients, maybe who believe in Lyme disease, they have additional virus infection. I said today, the starter is maybe Lyme. You had Lyme. It started 20 years ago, 10 years ago. But the menu is the virus, because your immune system is damaged. And then the virus is blowing up, like it's exactly with the HIV model. It's exactly with the SARS-CoV-2 long COVID patients. You know, these viruses blowing up, and then we don't use antibiotics. Either we use virostatics to treat the virus, or we use herpes, or we use transfer factors, or the combination, or we support the immune system. We need something antiviral, you know, we need more antivirals, that's for sure. And what we know now, maybe postulation number 3, we know that all of these pathogens can do biofilms, and by these biofilms, if we destroy them and we have new remedies, we can destroy the viruses indirectly. We can destroy the bacteria indirectly. Why? Because the biofilms, they have the functionality to protect the pathogen, the virus, and the protozoal infection and the bacteria, but they also are chatting rooms, you know, communication area. It's named quorum sensing. And if you destroy that communication, they cannot replicate. They cannot chat with each other. You know, the network is not working, so, and they don't know what to do, and they cannot replicate. That's a way to bring them under control.
And have you seen any atypical results in long COVID patients?
Typical results. Yes, it depends what you're doing. I'm convinced that the infusion therapy is more powerful than oral pills or capsules, or what you swallow. That's the resorption. Maybe you do some sublingual, where the resorption is better. I studied pharmacy also, you know, so it's better to use sublingual, or liposomal you could try. But the infusion therapy, and if you could do that, would be my first choice in that. And if you do that, you have a very good chance to come to a really good immune system, and then you have the chance to bring these pathogens under control back, and then you feel healthy. That doesn't mean that if you don't reduce your stressing factors, if you don't change your nutrition, if you get the next infection in your body, the next tick bite or next SARS-CoV-2, you get a reactivation. So that's no guarantee, but I'm sure that we will not kill all of this. We need to bring them into friendship mode, you could name it, okay, to arrange with it. But some of these pathogens, viruses, are very aggressive. They do cancer with us. So please stop them. In this case, we need to do everything, maybe virostatics.
Mm-hmm.
But we cured, if you want to hear the word cured, sure, it's curable. You feel 100% fit after that. Yeah? You feel much better. Look like me, people saying, all telling you you're good. Yeah, I said I'm feeling pretty good, although my stress level is boom. You know, it's good to do some, but you need to do something. Change nutrition, change lifestyle, reduce your stressing factors, have a good partnership, and so on.
So my final question would be, from your perspective, what are the key takeaway messages you would like to share with both medical professionals and patients regarding the infections of tick-borne infections and long COVID, particularly concerning testing, diagnostics, and treatment?
Yeah, my message is clear. I think so. It's a 3I. Think about it. Think about the infection. Think about, the opportunistic infection, all the spike proteins circulating. Think about the infection. Think about the immune system, and think about the inflammation. And if you think about that, and if you diagnose and treat it, you have the best options for the patients in every infection we are treating and every symptom we are treating. But it's not a guarantee. Please, that's also take-home message. Every patient is different from the other. There's not one size fits all. Not no wonder drug we have developed meanwhile, although some doctors, they say, then we put in curcumin, artemisia, and whatever in this wonder pill. It doesn't exist. But genetics is different. Epigenetics is different. Also environment is different. Nutrition, stress, it's all different, you know. So where you live, and age plays a role for sure. Natural immune decrease. So we have a lot of aspects, but take home message clearly 3 I's: infection, inflammation, immune dysfunction.
Thank you very much for your time. The final message for the audience. So don't forget to leave your comments. If you have any questions, we will be happy to share these questions with Dr. Schwarzbach. And maybe organize another webinar where we could discuss these questions in more details. Don't forget, we together can spread the message and awareness and support those still battling with the effects of long COVID. So up until next time, thank you for being part of Long COVID Foundation channel. Take care, everyone. And remember, knowledge is the power. Take care and goodbye.
Bye-bye.